Sorry. Hello, everyone. My name is Dr. Jessica Johnson. I am an ST2 in chemical pathology at the moment, but as I will explain, that's not really something that you can apply for anymore. So a little bit about myself. I currently work in and train in Sheffield. And yeah, just going to let you know talk about chemical pathology and how you enter it, what it is, and that sort of thing. So generally the first thing when you tell people that you do chemical pathology, they go, what? Who is that? And not many people know what we are, and even if they have heard of us, they still don't know what we do. I think even a lot of the other like histopathologists don't really quite know exactly what it is that we get up to and what our role is in the lab, and how we do anything. But I sort of like to think of us as the guy in the chair of medicine. We do a lot of stuff. We are sort of the back. We sort of take care of the backbone of most of the medical profession behind the scenes. So if you think, so here is something the Royal College of Pathology put out for Pathology Week. And obviously they like to make pathology sound amazing. So I have highlighted all of these things that are mostly down to chemical pathology. Pathology, 70% of all diagnoses. You go, what? How? You know, people think of pathology, they think of sending off a surgical sample to see whether or not something's cancer. But chemical pathology is blood tests, except for the small parts of that are hematology and coagulation, which tend to be under the name of the hematologist, and blood transfusion. And we don't really do cultures, so that's microbiology. But most of the other tests are either chemical pathology or immunology, depending on which trust you are and how big an immunology department you have. But in a smaller DGH, it's often the chemical pathologist doing the immunology tests as well. So we do blood tests, urine tests, the CSF lactates, proteins and things, ascites, any of the things that come under clinical chemistry. When you look up your results on something like ICE, those are done by us. So of this almost 900 million tests each year, over half of those are clinical chemistry. So that's how we sort of get our way into preventing, diagnosing, treating, monitoring, making 70% of diagnoses, monitoring how organs work, making sure your liver and kidneys are working. Babies, the newborn blood spot screening is a blood test. That's chemical pathology. And we do some of the cancer markers. So yes, that's sort of how. So that makes us sound very grand. How are there very few of us? Oh, by the way, feel free to interrupt me with questions if there are any, and let me know. So what exactly do we do? So one of the main things that we do is something called being the duty biochemist. So we authorize test results. And that's basically looking at what result the lab comes up with and making sure that it looks like it's a true result. So we have a lookout for anything that might be interfering, or if it's an artifact, you look at it and you go, why is the sodium so low? And then we can add on things like lipids to see if they're high triglycerides. And then we add comments for things to help interpret. We do that a lot, especially for GP samples. And then we do something called reflective testing. So for example, if a GP sends a panel of LFTs, and they often just send something and it says monitoring, who knows what that means? And you suddenly see that there is a raised ALT and nothing else. What we will do would be to add on, for example, a gamma GT, an AST, and a CK, if those hadn't already been added on, just to help decide whether or not it's muscle, whether or not it's liver. and if they hadn't had the extended LFTs, to give them extended LFTs there as well, if they're going to need that for monitoring. And we do that for a lot of different things. So if there's an isolated raised ALP, we'll add on a bone profile if that wasn't already there, or if it was part of a bone profile, then we'll add on the liver profile. And again, we do that a lot for GP samples, not quite so much for hospital samples, but we do that too. It depends on what trust you're in with how many samples these they look at. We tend to look at anything that's very abnormal. Some tests we look at all of the samples that come through. We look at all the results for that test. Sheffield Children's Hospital, there they authorize every single result. In STH, we would have way too many samples. So generally if it's within the normal range, that's fine. And then we also have something called a delta check, where if it's very different from a sample before it, then we'd get that even if it was within the normal range, because it might be that the tests don't match up. So that's part of our duty. The next thing that we do is managing the lab. So we take the lead on things like quality control. We interface with the clinicians. They want a new test. They talk to us about whether or not we can set it up, or whether we can send it away, or we say why we can't set it up, or why we can't send it, or why we don't think it's a very useful test. We're often in charge of all the point of care things. We can sometimes be in charge of specialist services such as toxicology, and that sort of thing might involve giving evidence in a coroner's court. And then we also do see patients. So we quite often get it's quite often outpatient things that we get involved in. Our main things are lipids. So I'm not sure if any other specialty does lipids. There's metabolic bone, which is also often done by endocrine and sometimes rheumatology. Inborn errors of metabolism, also generally under the chemical pathology umbrella. I'm not sure if anyone else really does them. And that isn't done by most chemical pathologists. That tends to be quite niche, even within the chemical pathology specialty. We do help with diabetes clinics in some trusts and do some things like endocrine, like thyroids and things. And we also often help interpret thyroid tests, especially for GPs. And then other things that we were traditionally involved in nowadays is going more into gastro, is nutrition, but that is part of the training. We can also do it's quite a flexible specialty, so you can but you can do things like ITU ward rounds, where you go onto ITU and help there in case they have, like, to see if there's any artifacts or anything. For example, in our trust, because ITU uses a different system, they don't get us looking at their test results. Like, everything gets automatically authorized for them. Because otherwise they wouldn't get the results as quickly, and they wouldn't see the ghost reporting that quite often is done. So sometimes that's helpful. We can, see things and try and explain what might be happening if test results are quite odd. We also, as part of duty biochemist, we get phone calls from GPs and on the ward saying, this patient has this blood test result. Why do you think it might be? Or sometimes even asking for help for managing things. But mostly it's down to how do we investigate this further? What don't we do? We don't actually analyze the samples ourselves, which is what a lot of people think of when you go, oh, you're working in the lab. The biomedical scientists do that. They're highly specialized and highly trained. We do that sort of as part of our part of our training. We do go in the lab, get a feel for it. That's mainly so that you can have an idea of what might be going wrong with a sample. When when there is a problem, you'll actually know what's happened, what the sample journey is, so you can think of where the problems might be. And we do have to do some dots, things like use a pipette, put things in a centrifuge. But like it's sort of the dots are sort of being signed off for those sorts of dots are sort of along the similar lines of being signed off for chest drain as an IMT, where an actual respiratory reg in order to do a chest drain would have to do like 50 signed off before they're allowed to do it independently. And then we get them signed off and it's like competent. And we all know that we're not actually competent to do ourselves. We don't do histopathology. So we don't have to look at slides. We most of the time we get our information, all of what we get is just data on a computer screen. Occasionally we do some things that are interpretation, like say like a protein electrophoresis and looking at an electrophoresis sample. But yes, we don't really look down slides or anything. It's all there on a computer screen, which makes it a lot easier, especially if you weren't very good at looking at slides in medical school, like I was not. So why do chemical pathology? One of the best things is probably it's generally be a great work-life balance. As most of their patients are outpatient clinics. They tend to be quite chronic conditions, so it's not something that so most of our patients are well, or at least they are when we're discussing with them. If they become sick and go into hospital, then they tend to be underneath the actual physicians, and then we give them advice when they phone us if they remember to phone us. We have very flexible working patterns, so a lot of chemical pathologists will do something like 8 till 6 for 4 days a week and have 1 day off. And that's been going on for a long time. So one of my consultants, he said that when he started his job in the 90s, he had a great time taking Fridays off and going around with his sons, which when they were toddlers, which was not like a very thing that many men did back then. So, you know, it's very good from that point of view. You do on-calls in the evenings. They're often done from home. And what sort of things do we get done for on-calls? It tends to be if there's a quality control problem in the lab, and most of the time they let you know, and then you can see whether or not it's something that can wait until morning. And not often does it happen. The consultants tend to do a whole week at a time. It's not a very strenuous time to be generally. But like for things like duty biochemist, where you're authorizing results, that tends to just be done Monday during the working week, and then the on-calls are only for sort of lab emergencies. We have lots of opportunities for research because we get all the data. And we have the IT systems in order to search through it. So it tends to be a lot faster for us to find the data that we need, rather than trying to go through patients' records one by one. We do QIPs and things, and audits, and we take lab quality control very seriously. So getting QIPs and things lasts for a lot longer than one rotation, which was always a frustration of mine when I was doing IMTs, so core medical training. We don't really rotate hospitals, but if you don't have the specialties that you need to get done in your center, then you might have to go to somewhere else that does for those clinics, like once a week or something. Of course, now with like a lot of things being teleclinics, you might even be able to do them from home. So Sheffield has quite a lot already there. I did go across to the Children's Hospital, which is a separate trust, in order to get experience with the pediatric samples. I know that the person in Leeds will be doing the inborn errors clinics with us because they don't have an inborn errors service there. And I think possibly the people in Hull and York might come to us for metabolic bone clinics when it comes time for them to do that. We get time to study for exams within our actual work. So when we did our open day with the Royal College, when they did like their welcome day, which was on Zoom because it was a pandemic, but they said, you know, you shouldn't be doing more than two clinics a week, 3 at a push. So that way you have time to do learning, because that it is very different to most of the things that you learned in medical school. Though it's quite depressing going over my notes from like first year medical school and going, I did know this once. Here I was writing writing comments along the porphyria pathway. It was like, I did actually know this at one point. But because you actually give time, you get time to study for it while you're working. It's not quite so bad as like trying to study from part one or something while you're also rushing around the wards. It is a small community. There are not many chemical pathologists around. They've got like a big mailing list from the chemical pathologists and clinical scientists. And so they quite often, like, you get questions and people being like, does anyone offer this test? Or we've got some very weird results. Does anyone have any ideas? Sadly, I have yet to go to a conference in person because of the pandemic, but I get the impression that when those do happen, you know, most people sort of know each other and that sort of thing. Your own desk, that was a big draw for me. I don't know about people, other people, but it's nice not to be sort of shuttling around the wards every 4 months, stuck in a tiny little doctor's office. Even I got 2 screens. So what does it offer? Procedures. Some people really like doing procedures, and we don't see inpatients. So unless someone were to collapse in your clinic, which, you know, may happen, you don't really have to manage anyone acutely, which is good for me. But you know, some people miss that. I put down recognition because no one knows who chemical pathologists are. No one even thinks about us, even when there's something in the news that has to do with chemical pathology, like, for example, an entire blood tube shortage. And what are we doing about it? There were people talking about from the GPs and the BMA. No one really seemed to find out what the chemical pathologists were actually doing in the background to try and help with that. And then obviously no one ever knows what we do. So you can be like, oh yes, if you say you work in A&E, people tend to know. If you say you work in GP, people know what a GP is. If you say, oh yeah, I work with, you know, I do nephrology, I work with kidneys, but no one knows what chemical pathology is, even after you try and explain it, really. So how do you become a chemical pathologist, which is what most of you are probably here for? So it's recently changed. It's changed in 2021. They started letting in people. So it used to be that you could either do metabolic medicine, which was after core medical training, and you had to have bases for that. And that was ST3 entry and lasted for 5.5 years. And then you also had a run through from where you could apply from an F2 level, from ST1 to S training, is chemical pathology. They have now got rid of the F2 entry and changed it to just changed the name to just chemical pathology. But they have also expanded who can apply. So not only is it the IMT2s, but it is also people who have done PEDS, people who have finished ACCS, so acute core STEM, people who have finished the first part of anesthetic training, and then people who have successfully done GP training, and then also whatever broad-based training is, which seems to be like kind of a sort of like GP meets IMT type thing. But so I'm not entirely certain. I will confess to what broad-based training is. But basically, if you've done any of these things, then you can apply straight to being an SD3 as chemical pathology. Why have they changed it to be that? I'm not entirely certain. I might suspect that it might be because we weren't getting many people applying from F2 because they didn't really know what it was then, or we didn't have like the draws, which might be a bit more of a draw. My husband says the draw of chemical pathology might be its more mundane nature, where after you've spent your time on the wards or in GP or PEDS training on the rotas and things, and you think, I can't keep going like this. I need a better specialty. And then you go chemical pathology. Now that sounds good. Whereas before it was like, do I really want to be sitting on a computer screen all day? People go, will you miss the hustle and bustle of the boards? Not anymore. But as I said, it's different things for different people. So So that's that. So what were the interviews like? So I did actually do the ST3 interviews for metabolic medicine, and I was successful, but the job would have been in a different city. So I chose geography to go for the ST1 entry. So that was 2 15-minute interviews. We were given time to look at the clinical cases prior to the, so I think we had 15 minutes, maybe 30 minutes. We sat and we looked at, and we were given the scenarios. We sat there, we looked at them, had a think, and then we went into our interviews. So in each interview, there was one clinical case each. I think they tend to set it as like one electrolyte disturbance or something, which will probably be sodium, potassium, calcium, maybe magnesium, either hypo or hyper, the other ones. And then one would be an endocrine question. So I would say probably the most think about what the most common things would be. So cortisol, maybe cortisol, thyroid, diabetes. I would say probably those are the most common ones, maybe cons. And then each stage, one of them was clinical governance. So what, questions that you expect for clinical governance. What is clinical governance? What is DATEX? Why is it important? What QIPs have you done? Tell me what was the important part of the QIP? Tell me about the PDSA cycle, those sorts of things. And then portfolio, which also involves commitment to specialty. I would say a lot of it sounds from talking to other people who've also had interviews that the commitment to specialty is mostly assessing whether or not you know what chemical pathologist does and what their day looks like. Have you actually thought about this, or have you just applied? Because a lot of people don't know what chemical pathology is. And because a lot of people don't know what chemical pathology is, many medical schools, it isn't really covered very well. They're not really expecting that you'll be like, I have wanted to be a chemical pathologist since I was 3. And that is what I have focused my way on. And I have done 10,000 QIPs, and I've managed to have a chemical pathology rotation, which do exist, but are quite uncommon. And I have done this and that. They don't really expect that you will have managed to do that, but they will probably expect that you will have at least talked to some chemical pathologists, maybe managed to get into the lab and seen what they do. Gone to a clinic, which, to be honest, it shouldn't be that hard to try and find your way to a lipid clinic or a metabolic bone clinic, or might be harder to get to an inborn errors clinic because not every center does those. But there is probably somewhere that you can find yourself in a lipid clinic, or find a friendly chemical pathologist somewhere near you. And then I would say the main thing is, in the clinical cases especially, is to think like a chemical pathologist when they give you these blood results and say, what do you think of them? Think to yourself, are these real blood results? Is my hyponatremic patient actually hyponatremic, or is it pseudo hyponatremia? Is my high cortisol, is the low cortisol actually low cortisol, or has someone put them on steroids? Is the high cortisol actually high cortisol, or has someone given them a giant dose of methylpred and then taken the bloods? That sort of thing. Is there an artifact somewhere? Because that is what we think. And then obviously you have to think about what the clinical things are, but they're not going to expect you to be able to come up with some bizarre diagnosis, inborn error diagnosis that only a chemical pathologist would get, because, as I said, all of the you look at what all the people who have been they're going to be giving you questions that a GP trainee or an IMT trainee or a PEDS trainee or an anesthetist would be able to answer, because they're not going to expect you to have done. There is no chemical pathology really training that you'll have done prior. So I don't think they're likely to give you a lipid question, even though most of us will. Lipids is one of the few things that chemical pathologists mainly do. If they do, I'm very sorry. I feel like it's probably unlikely. I would probably focus on electrolyte disturbances and endocrines, because those are things you'd see on the wards or in your training otherwise, and would still. And as I said, we do lots of blood tests, and we have to be able to interpret all those results anyway. Competition ratio seems to be something people tend to be interested in. Whoops, go back. As you can see, it's not particularly competitive. I would have applied in 2020. I think I was number 16 of the interviews, and I was the last person to interview that day, which tracks about there. Then in 2018, 2019, there are actually less people applying than there were posts. So it's not particularly competitive. Maybe I am slowly managing to chip away and get people to know that we exist. I guess the question becomes, if you're so interesting, if it's such a great job, why does no one apply? I think it's because no one knows that it exists, and we sound pretty boring. But as I said, I think the main thing is the work-life balance is the draw. So they will probably be getting more people as more people know what it is. People want to know what sort of things you do while you're training. These are the sort of the specialty things that they put on in the curriculum. So being able to lead the laboratory, manage the laboratory, be able to make sure the laboratory is being used cost effectively, helping clinicians, doing multidisciplinary team meetings, contribute effectively to the management of problems in patients is mostly, like, as I was saying, about helping interpret blood results. And then the clinical service, that's the lipid clinic, metabolic bone clinic. Yeah. Training, a lot of people worry about the exams. Yes, the exams are difficult, but I have done part 1 for MRCP, and that was also not very fun. So I would say that, yes, it is difficult. And if you looked at the pass rate for FRC Path Part 1, that was done in September, that had a pass rate of 35%. But I suspect that I don't think most people pass on the second or third try, which is frustrating. But if you get time to at least do your revising during your training, that's a lot better. And lots of people fail MRCP Part 1 anyway at some point as well, and I'm sure lots of people fail for peds and what other specialties do on their first time as well. And then for Part 2, it's practical skills module, which is currently online at the moment. It's mostly being given interpreting data. And then there's clinical scientific management skills module, which is for medics. They'll give us a clinical question, similar to like what you'd expect in an interview type thing. It's a viva, and then ask you to talk about it. And then the written component module is interpreting a journal article type thing. What time is it? We've only been going half an hour. That is the end of my presentation that I have specifically, but I am prepared to answer as many questions as you have for what I may not have covered. Feel free to ask any questions.
Hi, Jessica. That was brilliant, really, really useful, actually. And there is a question.
Okay.
I'm not sure if you'll know the answer. It's just that someone is going to be applying for ChemPath with the interview coming up. They're just asking, do you know if the full MRCP is definitely required at all for it?
I think
they're an IMT2 doctor.
So according to it, you have to have passed by the time you start your job. You have to have finished MRCP. You have to have done the full MRCP for it. Yes. But I think like you can apply if you still got if you still got part 2 in PACES, and you can have the job. But I'm not entirely certain. It might be worth emailing HE about that. But I think you have to have it.
Perfect. No, I think that's a good idea. The email.
Yeah, but I do think I think when I read through the person criteria, it's like in order to apply, you have to have done part 1 and you have to be on track to have finished part 2 in PACES prior to starting your post. So you don't have to have done it prior to applying or prior to having your interview, but you do have to, and you'd be interviewing around March. So you'd have until August to start, I guess.
Right, perfect. Okay. Fine. Now, a couple of other questions, Jessica. Is there any particular reason that sort of drew you towards chemical pathology at all?
So I started out life wanting to do infectious diseases. And so I sort of did all my medical school placements for that, and had some posters in it. When I was in F1, I actually did have a chemical pathologist as my educational supervisor. And he was very lovely. Every time I would go, he'd give me like a little mini tutorial and a tour around the lab, which was always nice. And I told my husband about it, and he nearly applied for the job that I have. And yes, so sort of it was in the back of my mind from there. Also, my medical school did do quite a lot of chemical pathology and lab medicine as part of things. So we actually did get some tutorials by chemical pathologists and things, small group teaching. So it sort of was in the back of my mind. And then as I did core medical training and got ground down by not being able to, having to fight tooth and nail for your clinics, and then being like, and you're about to go to clinic, oh dear, sorry, we have to move people around, you can't have your clinic day. Can't go to training because there aren't enough of you on the wards and things like that. I sort of started wanting to jump ship. And I sort of was thinking of public health as well, which is very competitive. Around the same time, my husband was having similar thoughts about what he wanted to do. So he actually ended up phoning the duty biochemist and saying, is there anyone I could talk to about chemical pathology? I'm thinking about maybe applying for metabolic medicine. And someone going, hang on just a second, I'm sitting next to the TPD. And so he met up with her. So he had a long chat with her, and she was like, oh, we are thinking about opening up an ST1 post. But then he ended up getting an academic oncology job. And then by the time the next year came round, the post was, I contacted her again and found out the post was still open. And so I applied to chemical pathology. And so I'm happily in Sheffield, not having to rotate, sitting in a lab while I was on mat leave with my husband. One of the things that I really like was I was helping him do Excel spreadsheets for his lab data and things for his research project and thing. And I was like, you know what, this is something that I would be much happier doing rather than rushing around the wards, doing nights, not having time for lunch, that sort of thing. So it was a very roundabout thing. And on my first day when I went into metabolic bone clinic, the question was like, oh, how did you find the job? I was like, oh, I talked. It was like, but how did you know that chemical pathology was an actual job? So yes. Who is the chemical pathologists? Even the chemical pathologists are quite surprised when they find someone who wants to be chemical pathology.
Oh wow, that's really interesting actually. Yeah, I mean, no, it's true. I don't think it's sort of publicized as much as it could be, chemical pathology. So no, it's really interesting to get that insight about what it involves. And that was really a coincidence, wasn't it, that they were sitting next to the TPD? That's brilliant.
It's a very small. It's a very small specialty. Now the TPD is in Hull, so that wouldn't happen again here. But I would say that if you are interested in chemical pathology, that is the way to do it. Is the way to find it is to call whoever is your duty biochemist within office hours. There will be someone. It will either be a chemical pathologist or it will be a clinical scientist who are sort of like, they start out doing biomedical science as a training, and then they do like a specialty training pathway. And so they become, and they do all the things that we do, except they do the lab stuff. They don't tend to do clinics and things. So I think there might be some of them training to do clinics, but generally they do the lab management, interpreting assays. They get a lot more involved on like the lab side and the very specialist assay things. But not all trusts have chemical pathologists. Some do just have clinical scientists, but those clinical scientists will know who the closest chemical pathologist would be. I would say most teaching hospitals probably do have chemical pathologists, and then it's the district generals that may or may not have a chemical pathologist. They may just have a clinical scientist, but the clinical scientist should be able to signpost you to the nearest chemical pathologist, and then you can try and find them.
Okay, brilliant. I think that would be really handy for anyone who's wanting to find out more. And so far in sort of your job, what would you say you've enjoyed the most from the clinical role?
So what you mean, like what part of chemical pathology specialty? What do I enjoy?
Yeah, just any aspect really.
Any aspect. So I quite enjoy being the duty biochemist. It's not or looking at the results. You get to be quite nosy, trying to figure out what's there and what isn't. And it sounds a bit daunting when you start being in charge of all these blood test results. However, I was very well protected, like for trading. They didn't let me do anything on my own until like December. I started in August. I did like a little mini open book exam where it was like, if you don't know what the answer is, then the good thing is to say, I will contact a senior first. So yes, it was very different to like say my husband who started oncology and I think had like maybe a month of shadowing. We had quite a long shadowing before that. I quite enjoyed lipid clinics. Lipid clinics were a lot more interesting than I thought they would be. To start with, metabolic bone was okay, bit humdrum. Inborn errors, not as exciting as you would think.
Oh, okay, that's quite interesting actually. And in terms of challenges of a specialty, is there anything that you've sort of come across day to day that people might want to consider when applying to it?
So I think, especially at the moment with the pandemic, it's been hard to meet other people. There's so few of us. It's actually quite unusual that there's a second chemical pathology trainee in my trust at the moment. The people who started with me there's one by herself in Hull, there's one by herself in York. I think there might be two people in Leeds. So it's quite lonely in that way. We had a little WhatsApp group for the three of us who started at the same time, and then I've started a Discord server for trainee clinical scientists and the chemical pathology trainees, so that we could sort of get to know each other a little bit better. But it has been quite lonely from that point of view. Sometimes people quite often ask about sort of like what's the consultant post like. There are a lot of amalgamations of labs and things, and at the consultant level, you are sort of competing with the clinical scientists for jobs. But I think that there are so few chemical pathology trainees that the chemical pathologists do tend to get jobs, and there are certainly jobs where they prefer to have a medic around, because obviously we can do lipid clinics and those sorts of clinics as well. But those are probably the main challenges. But at the moment, we're so undersubscribed. I don't think finding a job is that much of a problem.
Okay, brilliant. Thank you. Fine. And in terms of your portfolio, or even in general, is there anything that you might recommend people do during medical school? I know you touched on a couple of things, sort of. I think you mentioned you were involved in a couple of things, but I think you sort of advice-wise for people to do in medical school in particular, like projects, ideas, or anything like that.
So I mean, I guess if you want to be, we are very, so because chemical pathologists involved in interpreting blood tests and things, it's very easy to sort of spin anything to be sort of relevant to chemical pathology. If you really wanted to go down the I've been committed for this for a long time, then I guess you could choose a project that had something to do with inborn errors or lipids specifically. Otherwise, if you're hedging your bets, which I would expect many people as a medical student would be, I would have anything to do with like looking at a blood test, like does this, like, I don't know, like looking at troponins in hemolysis, or potassiums in hemolysis, or blood tests, urine tests, things that have to do with tests of some description. You will be able to put that down as something to do with chemical pathology. And then you could also do it in the other specialty that you are also probably considering. And then you're doing a sort of 2-for-1 type thing. As I said, chemical pathologists don't really expect much from the commitment to specialty, other than I have gone and talked to a chemical pathologist and I know what they are talking about. And I've walked through the lab. I've been to the lab. I know the sort of people who, I know how a sample comes into the lab and leaves and goes into the machine. Sort of, they're not expecting detail. They're just expecting you to be vaguely aware of it, mainly, because they want to know that you have actually thought about this, rather than just going, that's a specialty. I'll apply for it, because they have no one else applying. But you can spin many things into commitment to specialty. I mean, just like, there are lab tests, there are blood tests, there are lots of tests out there.
Yeah, no, brilliant. No, I think it's very true. You can, you can do a blood test on more things, can't you? Okay, brilliant. Well, I think that's covered a lot. Thank you, and that's been really useful, actually. In terms of other questions, I can't see any others. We've got that form as well. So yeah, no, thanks again. And I think we might end it there, unless there's anything else you'd like to add, Jessica.
I can't think of anything. Apply, yes. I think it's a specialty that should get more recognition than it does, and you can see that in the competition ratios. I made it sound really amazing. I don't think I'm overhyping it that much. Obviously, I'm a chemical pathologist. We all tend to overhype our specialty slightly. But I don't think I'm overhyping it so much that people look at the competition ratio and then go, "This makes no sense." The problem is that people think, "Oh, we're working in a lab." What? They think we actually have to do the tests and on things, and they don't know what we do.
Brilliant.
All right.
No, thank you again. You're brilliant one. Okay, then. Well, thanks, Jessica, and yeah, hopefully more people apply to it. Brilliant.
Thank you so much. Have a great evening.